All right, welcome everybody. My name is Brady Mullen with Alpine Association Benefits. Stephen is on with us, who also works with us at Alpine. He'll be managing the chat feature. If you have questions, throw them up on the chat feature of Zoom, and he'll try to address those as we go. I'll keep my eye on that as well on a different screen I have and try to keep questions answered in real time if we need to do that or if we need more clarification. Another thing I'll say before we start is the relationship that Alpine has with CAR is that of we're advising with them, looking for the best options for healthcare solutions for realtors in the state of Colorado and in DMAR specifically. We have a close relationship with them as well. Ann and Lisa and Sarah there that we work with a lot. We don't work for any of these companies, Redirect, Sedera, who are some of the main providers of some of these solutions, or some of the insurers that we'll be talking about today, like Anthem and those Oscar and Friday, some of the things that are available in Colorado. We don't work with any of those. We're working with CAR to try to find solutions for realtors and be as comprehensive as we can and provide as many options as we can for different kinds of families, depending on their dynamics and situation. So if you have any ideas or if you hear about things that are working, please share that with us. We would like to make as many viable and good opportunities available as possible. So let's dive right in. We're going to talk about the resources that are available. The first thing I talk about when I do this is eligibility, who these resources are for, who can use them. And clearly the first one is Colorado Realtors. So if you're a realtor, your family can use this. The realtor, him or herself, does not need to use any of these benefits for the family to take advantage of them. So in some cases, whatever benefits are available just don't make sense for the realtor, him or herself, but it still makes sense to put family members on it. That's okay. It doesn't have to be used by the realtor in order for the family to take advantage of it. Next would be realtor assistants and staff. So if you have people in the office that have as hard a time dealing with healthcare costs as realtors often do, they can use this as well. We're trying to be as open-armed about this as possible. And then lastly, affiliate members. So whether they're affiliate members of DMAR or CAR at the state level, if they're, like independent appraisers or loan officers or inspectors or photographers, as long as they're participating in the local or state level realtor association, they also use these benefits, okay? So if you go to coloradorealtors.com, which is CAR's website, /healthcare, that will go to a site that we built that is designed to compare two major philosophies or approaches about dealing with healthcare costs. And those are medical cost sharing and traditional health insurance. We have resources now for both those, which is very exciting and a new feature. So the first thing we're going to talk about today is just categorically the differences between these two things so that you can make a high-level decision about what's appropriate for you and your family. So I break it down into two different areas where we compare them. One is how the money goes back and forth, and then the second one is the administrative philosophies behind the two different approaches. So we'll start with the funding. And I'm going to be talking about virtual direct primary care many times in this discussion today, but I'm going to abbreviate that as VDPC. So just know that that means virtual direct primary care, and which we'll talk more about what that means. So the medical cost sharing solution that we have available now is a combination of VDPC and medical cost sharing. We'll talk more about what that means. And then we're going to compare it to traditional health insurance. We don't have an opinion about which is better. They each have different advantages and disadvantages over the other. And it largely depends on, well, not even largely, I would say ultimately depends on the family situation and who you're trying to get benefits for. So we'll talk about that. So the philosophy behind VDPC combined with medical cost sharing is, from a funding perspective, the idea is just very simple. For the small medical needs, I as a member, I want to be in charge of those. I don't need help from an outside source to take care of a physical or a primary care physician visit that might cost me, $100 or $120. I don't need help with that. I want to pay those bills on my own. I can pay cash for that, no problem. It's only when I have large medical needs that I really want some outside help with that. Traditional health insurance has evolved into something a little more complicated than that. There's copays for the care that you get, And those are different formulas based on whether you're seeing a primary doctor, a specialist, getting labs, getting imaging like x-rays or MRIs, and then prescriptions. The formulas are more complicated with traditional insurance. So a doctor visit might cost me $20 or $30 or $50 instead of $100 to go see the doctor. They try to make the regular care a $20 cost instead of maybe $100. The annual deductible also resets, so that's another part of the funding formula with traditional insurance. Your annual deductible resets on January 1st. And then after you hit your annual deductible, you pay a co-insurance up until max out of pocket. I don't think this is new to anybody. Most people have seen how this works and they've had some experience with this. I'm using this really as a way to compare the two philosophies. And then medical cost sharing, medical cost sharing combined with VDPC has a significantly lower monthly cost. We'll talk about how they make that work later on. But traditional insurance, again, largely due to the ACA requirements of, I won't go into all of those right now, but we've all known that in the past, 4, 5, 6 years, traditional insurance has become very expensive, which is part of the reason that medical cost sharing has become such a popular option in the United States. Okay. Let's move on here. So from an administrative side, there are some philosophical differences between the two, and here's how they compare. One of the main features of VDPC, which again stands for Virtual Direct Primary Care, is that they want to control the entry point, and I think this is very important. And what I mean by entry point is, if I feel like I need medical care, where do I go? And the idea behind VDPC is the very first thing that should be done is a phone call. Now, I'm talking about non-emergency situations, right? If my thumb's on the floor in the kitchen and I need to rush to the hospital, and I'm not going to call anybody. I'm going straight to the ER, right? That's different. And there are ways of handling that with medical cost sharing as well. But for all things that aren't emergencies, the entry point should be a call or an instant message or a video conference. And that is available 24/7, 365, and you have no limits on how often you can use that with a VDPC. And then when that happens, one of two things is going to happen. They're going to be able to resolve your issue over the phone through the VDPC doctors. And I'm going to make a comparison about how this is different than telemedicine later. It's like telemedicine, but with many more advantages. We'll talk about that later. So 80% of the reasons, or 80% of the calls that I make to VDPC, 80% of the time, that can be resolved without going anywhere, right? They can look at me, they can talk to me, they can order labs, they can order tests, and that can be resolved without me going into a doctor office and doing a regular visit. And then 20% of the time, I do need to see somebody, a doctor physically, and the VDPC can help coordinate that and put that together so that can get resolved. We'll talk more about those details later, but that's the philosophy behind VDPC and medical cost sharing combined. Whereas traditional insurance in the past, and I think this is evolving to a better place, but traditionally the entry point is you go somewhere. You either set an appointment or you go to an urgent care and you see somebody, and that can get costly right out of the gate. Whereas calling the VDPC, there's no cost in that. You have unlimited access any time of the day, any day of the year. So their idea is, hey, if somebody doesn't need to see a physical doctor in person, let's avoid that, and that keeps the cost way, way down. And not to mention, it's also much more convenient, right? I don't have to go anywhere to talk to a doctor, whereas if I'm here, in many cases, I've got to go somewhere to see somebody. With VDPC and medical cost sharing, there's no network considerations whatsoever. And of course, anybody who's dealt with traditional health insurance knows that networks matter. In-network formulas are different than out-of-network formulas, and so on and so forth. You don't have to worry about that with VDPC and medical cost sharing. There is also no enrollment with VDPC and medical cost sharing. There's no enrollment limits or periods that matter. I can enroll any month that I want. So enrollment happens. Start dates are on the 1st of every month. You just have to be enrolled by the 19th of the previous month. This is different than the last iteration of benefits we were offering last year. Those are still available, by the way. We'll talk a little bit about that, but it used to be the 20th. You had to be enrolled by the 20th, but due to the technology that we're using and some changes that have been made, that is now the 19th. You have to be enrolled by the 19th to have a start date of the 1st on the following month. And then, of course, traditional insurance is subject to enrollment windows. So there's open enrollment every year between November 1st and December 15th. Other than that, if you want to enroll in insurance, you have to do it based on a qualifying event. So getting married, getting divorced, losing a job, and therefore losing benefits, those will allow you to buy insurance outside of that open enrollment window. But if you don't have one of those reasons and it's not open enrollment, you simply cannot buy traditional health insurance. Now, coincidentally, we are in an open enrollment period that is unusual. It's been opened again due to the coronavirus. So if you don't currently have insurance and you would like to get insurance, you can do that right now through April 30th. That's important to know. Maybe that matters to some of you. How your care plan is determined is different when you're dealing with VDPC and medical cost sharing versus traditional health insurance. So the care plan is determined by the doctor and you, the patient, whereas many of you, I'm sure, have had experiences where your doctor recommends a procedure, but your insurance has to approve it beforehand, and they sometimes don't approve it. They'll say, well, we're not going to do this until you try this first because it's less expensive. And the insurance companies often get very highly involved in the plan that your doctor recommends because they're well, for lots of reasons, but they're involved. I'm sure many of us have had experiences with that. Here is an important one, which is why I underline it. It's important to know that VDPC and medical cost sharing, they do place some temporary restrictions on benefits related to pre-existing conditions. So if I cannot join a medical cost sharing community with a bum shoulder that I know needs surgery, join the community and then get funding for that surgery right away. It doesn't work that way. We have a whole slide dedicated to how this works. And so we're going to go over that in more detail. But one of the ACA requirements that came out a few years ago were that insurance companies cannot place any restrictions on pre-existing conditions. So there are no pre-existing condition restrictions on traditional health insurance, where there are some temporary pre-existing condition restrictions with medical cost sharing. We'll talk about how those work and what those apply to, but I think it's important to note up front that it doesn't mean that if you have a pre-existing condition that you can't use any of the benefits. In fact, it's only one of the benefits that you cannot use, and it is temporary for pre-existing conditions. And we'll talk about those details in a bit. But this is probably the most important or the most commonly noted deciding factor as to whether this is appropriate for you and or your family, is whether or not you have pre-existing conditions that you expect are going to cost you some major medical bills in the near future. If you do, and there's maybe a surgery upcoming and you know that you're going to need that, or you're afraid that you might, traditional insurance would probably be the best choice for you. If not, then medical cost sharing is a viable option to consider. Okay. I'm going to talk about traditional health insurance first. Our resources here, I think, are fairly, it's not that they're simple, but people are familiar with them. People have shopped insurance before, so I'm going to show you these resources pretty quickly. And I think you guys will know what to do with these resources when you see them. But for this, I'm going to bring up a website. When you go to this coloradorealtors.com/healthcare, that's going to point to this site that we built for these resources. And this site is designed, again, to give you those two paths, medical cost sharing or traditional insurance, and there will be resources where you can read about them to help you determine whether or not it's right for your family. I'm going to go down the insurance side first to show you what that looks like. Here's some resources. Here's a little bit of a couple of paragraphs or several sentences about why association plans are not yet available in Colorado, and we are keeping our eye on that. And when that happens, we will definitely be looking into that for the realtors. But if you decide you want to go down the insurance option, you would click here. It would take you to a site where our specialist at Alpine, Rita Lenz, who's been in the industry doing insurance in Colorado for 25 plus years, she is our specialist on the insurance side. She is available to help if you need assistance, but it will give you all of the plans that are available based on your zip code and based on the situation of your family. So I brought this up in advance before this webinar, so we wouldn't have to watch me go through that. But I entered my information as if I lived in Denver. and I'm a 55-year-old man with a 55-year-old spouse. And it brought up these plans. It looks like there's 10 per page, and there's, you know, at least 40, maybe up to 50 plans available for me and my spouse. And this is ordered in the in order of lowest premium. So the cheapest one that I could get for my spouse and me is $1,007 per month. Okay, and then it goes, and you can compare options, and there's all sorts of resources here. The advantage to using CAR's resources for the insurance isn't in discounts. That simply is not allowed at the state of Colorado at this time. That's what we're hoping to achieve when association health plans become something that Colorado adopts. However, the advantages are here that you will have access to plans that aren't available on the Colorado Exchange. Some of these plans are available on the Colorado Exchange for the exact same cost and with the exact same benefits, but there are some plans here that are not available on the Colorado Exchange. The other advantage is that you have a resource that understands what you're going through, that helps individuals, and it doesn't cost any extra to use her to help you make decisions on the traditional insurance. Okay, now I'm going to go back. Does anybody have questions? Throw them up there on the chat feature. I'm going to check it out. Okay, looks like Steven's staying caught up with everybody there. Okay, so again, this isn't necessarily simple, but I'm not going to spend a lot of time on it because I think it's fairly familiar to everybody. People have looked at insurance through these kinds of sites before. So we are going to go back to the presentation and talk about now medical cost sharing. I spend a lot more time on this in the presentation, not because we prefer one or the other, but because it's less familiar to people. So I want to explain how this works and the groups that we've brought together to make this benefit available to members in Colorado. Okay, so the comprehensive solution that we now have available is a combination of two different firms offering benefits. They have a close relationship with each other, Redirect and Sedera, and we'll talk about the different benefits. And for the most part in this presentation, I talk about the benefit as a whole, even though it's made up of two different groups that are offering these benefits. But just know that there's two different solutions, or two different components here in the solution. So let's talk again philosophically about virtual direct primary care first, because that's the entry point, if you remember from that previous slide. There's an article about the difference between telehealth, which is like Teladoc and LiveMD, versus primary care, virtual direct primary care. And I just thought this sentence or two was useful in kind of helping understand the philosophy of how this works. So one of the reasons virtual direct primary care exists in the first place was trying to make using the healthcare system more simple for individuals and less expensive. In this sentence, I'll just read it out loud because I don't think everybody that joined is seeing the video. Some people have just called in. So it says here, accessing healthcare appropriately and cost effectively is wildly difficult, especially when people think they need a doctor fast and default to the ER or urgent care center or go directly to a specialist for care. And the second they step foot in the healthcare system, the system attempts to bill them as much as they can, which is clearly not good for Sally member here to be build as much as the system possibly can. There's a more effective way of getting that sort of care. So the entry system is different. How we get into the medical care system, we want that to be as effective and cost effective as possible. So this is an image that I like that helps compare what virtual direct primary care was trying to accomplish. When you're in the medical system, in many cases, there's a lot of pieces flying around. There's billing, there's labs, there's doctor visits, there's hospitals, there's surgeon, there's anesthesiology. All those different components are needed to get the care that we need, but in many cases, it's the member that has to navigate all those pieces. VDPC, the solution that they've built is that you have a care logistics team that helps you do all of that. You're certainly welcome to call all of those components and deal with them yourself. However, you've got a coach here that will either do it for you or help you walk through and navigate that system so that you can call one place and they can coordinate all those pieces either with you or for you and help you get the care that you need. And if the answer is, hey, look, why don't you just talk to one of our doctors on staff, which is, Redirect handles this for us. And they have 27 doctors on staff 24/7 that can take care of most problems over the phone. We'll talk a little more about that. But if that's the solution, that's cheap because it doesn't cost anything to do it. But if you need to go get a lab, they can order labs directly from the care logistics team. They can order x-rays. They can help you go and get the care that you need efficiently, quickly, and cost effectively without this web of a mess. So that's just a visual depiction of how this is designed to work. Okay, sometimes people will compare VDPC to telehealth. I'm a big fan of telehealth, by the way, and VDPC in general. If you've heard me talk before, I talk about how great it is to be able to call the doctor at 11 o'clock at night or 4 in the morning for a kid that has an ear infection, or if I've got a sinus infection or something like that. It's an awesome evolution in the medical world. However, VDPC is like telehealth on steroids. First of all, it's important to know that they're both accessible 24/7, 365. The advantage to VDPC when it comes to who you're talking to is telehealth is going to have a network, no matter which vendor you choose. Telehealth is going to have a network of doctors all over the country. And when you call in, you're going to be talking to a random doctor, whereas VDPC, you're talking to the same doctor for that issue throughout the completion of that issue. So if it's something, let's say you call in and you have a rash or something, the doctor can say, well, this looks like this. I'm going to give you a prescription, but I want you to follow up in a week and we're going to see if that's looking better. And if it's not, we're going to try something else. They can make those kinds of decisions and confirm suspicions and so on and so forth. Whereas with telehealth, they're going to prescribe you something and that's it. And if you want to follow up on that, you would be following up with a new doctor, depending on who answers the phone at the time. These two things are kind of related to the one above it. There's no follow-up with telehealth, whereas with VDPC, that same doctor is going to follow through with that diagnosis until there's been resolution on the issue. This limits severely telehealth's ability to diagnose things. So they're limited to simple diagnoses only, like pink eye or sinus infection, stuff like that. Whereas with VDPC, there's no limitations on what they can diagnose. That doesn't mean they can diagnose everything, of course. There's no doctor that can diagnose everything, but there's no inherent limitations on what they can diagnose. And telehealth, they can't order tests, x-rays, labs, biopsies, etc. Whereas VDPC, they can do that. They can say, well, you're calling because you hurt your ankle. Let's order an x-ray. And then when I see that x-ray, we'll determine next steps then. So that can happen through VDPC, whereas it doesn't happen through telehealth. There's no care coordination with specialists through telehealth, whereas in that example, let's say where your ankle hurts, when that doctor sees the x-ray, they can say, hey, this is not a sprain, this is more complicated. You need to talk to a surgeon. Let's find a surgeon in your area that does these that can talk to you and take care of this and help coordinate that. And I put this in quotes, not that I'm quoting anybody famous, I'm actually quoting myself. The way that I would put this in words is, you call telehealth when you already know what you need. So I can't tell you how many times as a parent I knew my kid had an ear infection, but it still cost me $125 for a doctor to tell me that and to write a prescription. So telehealth is a great solution for things like sinus infections, ear infections, pink eye, stuff like that. When you already know what you need, you just don't have the ability in our current healthcare system to write yourself a prescription or your child a prescription. Telehealth is a great solution for that. Whereas VDPC is you actually have a doctor relationship, a patient-doctor relationship. They can do all the things that telehealth can do, plus a lot more. So that's the difference between VDPC and telehealth. Let's see, looks like we're caught up on questions on the chat feature. Okay, this is an important slide when it comes to how things are resolved when we call redirect. This blue part of the chart means that it's handled over the phone or over the video conference, or they even use instant messaging. If I call, the doctor's there, they can help me get what I need 80% of the time. And then about 20% of the time, they refer it out to a physical office or chiropractic or a specialist or a hospital because they're not able to help over the phone. But they will follow up, however, to make sure that your issue was resolved. That's important to know, because everything here in the blue, that doesn't cost me anything extra. This comes with the membership. Once I'm a member, if I need to call redirect to get some help, there's no limits on how often or when I can call them to get that kind of help. So that doesn't cost anything. That goes back to the entry point of the system. How do I get in to get the medical care that I need? This is the most efficient way to do it. Okay, so with membership here also comes the prescription discount plan, which again, redirect, the VDPC helps coordinate this. So if you need a certain prescription, they can help get that to you for the cheapest cost possible. Also included, when you go down the medical cost sharing path from the two different philosophies that we discussed initially, Anything on the medical cost sharing side has been set up to have dental and vision discount plans included for no extra cost. I'm not going to go through the details on this. These are available in the benefit summaries, but just know that if you enroll with the medical cost sharing, it automatically comes with dental and vision benefits. Those are available on the traditional insurance side, but they're not included. So you'd have to shop for those independently. Again, I won't go through the details here. I'll stop here for a second if you guys want to linger here a little bit, but dental and vision plans are included. Okay, so next we're going to talk about when things get nasty. So when medical bills aren't those small medical bills. So we talked initially when we were comparing medical cost sharing to traditional insurance. The idea was that, hey, for small stuff, I'm okay taking care of that on my own. For large stuff, I want some help. I want some backup. The nice thing about Sedera and many of the cost sharing options is that you can determine yourself based on your own finances what constitutes a large medical expense and what constitutes a small medical expense. We'll talk about how you decide that in a minute. That's called the initial unshareable amount, or an IUA, which is similar to a deductible on an insurance plan, but it's basically you telling them at what point would you like help paying medical bills. Is it $500? Is it $5,000, or something in between? So when things get nasty and we pull in the Sedera benefits, let's talk about how that works. So this is the cost sharing component of this solution. These different elements of how cost sharing works, or some of their pillars, so to speak, we kind of talk about them in passing as we go through this presentation, but there's two of these that I want to point out as we go. And the first one is people over numbers. So the pool of money that exists because Sedera members are contributing monthly into this pool that's available for members' medical expenses, that pool does not belong to Sedera. It belongs to the members. So they don't touch that pool. They just basically authorize money being released from that pool for medical care to make sure that it's not being sent for pre-existing conditions, or there's some other restrictions like they don't pay out for injuries sustained while committing a crime. It's just clear in the community guidelines that that the community money is not for that, right? So the way Sedera makes money is they have legally binding guidelines that allow them to take 9.9% of the monthly contributions that members make from that pool to administer the necessary technology, the accounting, the advocacy, the service, the people on the phone, everything that it takes to make that work. So there's no incentive for them to not help the members. They don't profit by turning members down. That money doesn't belong to them. They never touch it. And that's huge. That means a lot. Not all cost sharing groups are like this, and that was important to us when doing due diligence on these and offering these to members in Colorado, to CAR members. The second thing I wanted to focus on was the sharing on a per need basis. I've got a couple of slides about this. So rather than doing the annual deductible route that resets every year, they share on a per need basis. So we'll talk about how that works. Okay, let's see. The way I'm going to describe a need is this. Well, let's just read this right off the bat. So a need per Sedera, they use a capital N to describe this. It's one or more medical expenses caused by a single accident or illness. So I'm going to go through an example where I talk about, I'm skiing in December and I break my leg and it's a nasty one. It's not just a simple, go home and it's bugged me for a few days and then I go have it looked at and what do you know, I've got a hairline fracture. This is a nasty one. I have to take an ambulance ride. I go to the hospital. There's 7 or 8 bills that the hospital gives me based on the surgeon, the anesthesia, the bed, everything else. There's imaging, there's follow-up doctor visits, there's rehab. All of those bills that come in based on that accident are considered one need by Sedera. Now, the example that I use of a broken leg is useful, but I want you to know that it could also, this could also be an example of a heart attack or a stroke or a cancer diagnosis. It doesn't have to be an actual accident. It could be just an illness. So again, a need is one or more medical expenses caused by a single accident or illness. So all the bills that come in from my broken leg, let's say that those things add up to $28,000. And I've chosen, when I enrolled, I chose my IUA to be $500, meaning that I'm okay handling my medical expenses below $500, but once it hits $500, I need some backup, I need some help. So I've chosen that in this example to be $500, and that you do when you enroll. That means that if I accumulate $28,000 worth of medical bills from this accident, My responsibility would be $500, and then the Sedera community would provide funding for the remaining $27,500. Now there's some steps in there where they're going to try to negotiate those down with the providers to try to preserve and to be good stewards over that pool of money, but that won't affect you. So if they would like to negotiate that $27,500 down to $20,000, they're going to try to do that. But whether they're successful in that or not doesn't determine whether or not they provide funding for those bills. Down here, I want to remind everybody there is a limit of how many times you would be required to pay your IUA. I don't want anyone to misinterpret this as a limit of how many times you can use Sedera benefits. It's only a limit on how many times you would be required to pay your IUA. And that limit is 3 for an individual and 5 for a family. So if I'm a particularly clumsy adrenaline junkie and I just am always hurting myself and I have a 4th accident in a given year, I would not be paying my IUA a 4th time. You can kind of think of this like a max out of pocket. We don't call it a max out of pocket because you still may be responsible for a $100 doctor visit for whatever, if you need to go see the doctor. So it isn't really a max out of pocket, but you can think of it as a max out of pocket for the large medical expenses. I would only be responsible for $1,500 if my IUA was $500 for my medical needs, my large medical needs. Okay, I hope that's clear. If not, throw a question up there on the chat and Stephen will try to clarify. Now let's talk about pre-existing conditions. This is important. I'm going to spend a little time here. First, let's talk about defining what a pre-existing condition is. A pre-existing condition is a condition for which you've had observable symptoms or you've received treatment within 36 months of membership effective date. This is important, and this is also one of the reasons that we work with Sedera and not some of the other cost-sharing communities, because some of the other cost-sharing communities define pre-existing conditions as simply pre-existing conditions. So if you were born with something that made you predisposed to something, there have been bad experiences with some of the earlier cost-sharing models because they would define pre-existing conditions too openly. Well, Sedera has very articulate definitions of what pre-existing conditions are. If you have had symptoms or treatment for something 36 months prior to your effective date, then that would be considered a pre-existing condition. The reason for this, I think we can kind of all understand why they need to put something like this in place, because I can't join the community, pay my first month's contribution to the community, and then get a $28,000 surgery on my shoulder that I knew I needed already. If it wasn't a pre-existing condition and I had an accident the day after joining, then the community funds would be available for that. But if it's pre-existing, the community funds are not available for that for the first year. In the second year, there's a limit of 15,000. In the third year, there's a limit of 30. And then after 4 years, there are no restrictions on anything, whether it was pre-existing or not. There's no restrictions on the community funds for those conditions. Okay, I just want to go through some notes that I have on this slide to make sure I don't miss anything that's material. Remember that this restriction or these temporary restrictions only apply to the Sedera community pool of money being used to pay for procedures or treatment for pre-existing conditions. There are no limits on the VDPC benefits that we talked about earlier, the regular doctor visits, the prescription benefits, the vision, the dental, the care logistics. All of those benefits are available for you with no restrictions, whether the condition is pre-existing or not. It's just treatment and medical care for a condition that is considered pre-existing based on this definition. Okay, I hope that's clear. It's a very important thing to note. I don't want to spend too much time on this if we don't need to, but I do like to make sure that that's very clear. Okay. Oh, one more thing I wanted to mention about this. A lot of times people ask about, say, medications, if I'm on a medication to keep my cholesterol low or my blood pressure. Those are two really common ones. Sedera doesn't consider that a pre-existing condition if you haven't had symptoms or treatment in the last 36 months. So if I join the community and I've been taking a medication for cholesterol for, it doesn't matter how long, I've been taking it when I joined, I've been taking that drug, but I haven't had any symptoms or received any treatment for a heart condition or a cardiovascular condition. And then, 3 months down the road, I have a heart attack or something scary. If my only treatment for high blood pressure was a medication, they're not going to consider that a pre-existing condition. That's a specific issue with blood pressure and cholesterol that they don't consider it pre-existing as long as you haven't had a scare or any kind of treatment outside of just a regular medication 36 months prior to your effective date. Okay. Somebody asked, I want to bring this one up. If Sedera negotiates bills, if it's due to a pre-existing condition, like to help you negotiate prices for your own care, and the answer is yes. Redirect does that as well. So they will negotiate. If you need a shoulder surgery and you know you need it, it's going to cost you say $10,000. They will help you negotiate that down. They just simply won't provide the funding for it. So that's a good question. So I like to bring that up. So they take very good care of their members. They just restrict funding for that. And as a member myself, this is the exact plan that I use, what we're talking about today. Everybody that participates wants Sedera doing some kind of negotiation because that pool of money is valuable. It belongs to us. So we need them to do that. Okay, questions on this? I think this is clear. I hope that it is. We're going to move on to that. Lastly, I'm going to bring up, I mentioned this a little bit earlier, but redirect, we talked about this image before. This is redirect that handles that. One of the nice things about redirect is they have thousands of members that also use Sedera, and they have a very close relationship with Sedera. So if you're a member and you're using redirect and all of a sudden, let's say in this example, Salary calls the care logistics team because she's not feeling well, she sets a doctor appointment, she goes in and sees the doctor, maybe she handles that through VDPC, and they come back saying, hey, those symptoms aren't benign. We need to get some testing to make sure something's out of the woods, or you're out of the woods. And let's say that turns into something a little more scary for Sally than just an upset stomach or something like that. And all of a sudden she's dealing with doctors and specialists to take care of something more serious. Well, because Redirect and Sedera have a very close relationship, they know that Sally's a member of Sedera, they know what her IUA is, and they know when to get Sedera involved because something that was a small medical expense, or what Sally expected to be a small medical expense, turns out to not be a small medical expense. It turns out to be complicated. Redirect knows when to get Sedera involved to help use those benefits for your care. So it's a very nice marriage between these two providers and the realtors in Colorado. Okay. Somebody asked a question about the pool of money at Sedera. I'm going to answer that right after we talk about pricing. That's an important question because sometimes, I probably hear 3 or 4 times a week, people will say, this seems too inexpensive or too good to be true. How does it work? There's a couple of points that I want to bring up as to how this works. So first, let's talk about pricing, and then I'll get into that. You'll notice up top here, you are able through CAR to purchase the benefits through Redirect without getting any Sedera benefits. This is a little bit of people will do this sometimes if they have a catastrophic policy or something through a spouse, maybe through the spouse's work or something like that. You can get those benefits, those care negotiation and care logistic benefits, and that can be useful if you have a high deductible policy, because with a high deductible policy, you're paying cash rates for your stuff anyways. It's nice to have somebody help you do that inexpensively, or have a doctor available on the phone all the time that can either help take care of an issue or help coordinate care for an issue. So we have some people that do this just because they have a different solution for their big expenses besides Sedera. So we're making that available, and these are the costs for doing that. They don't depend on age. But as soon as you add Sedera, Sedera's prices are age dependent. So there's a bracket here if you're aged 18 to 29, 30 to 39, and so forth. This isn't available at 65 or older simply because Medicare is a good option. It's very heavily subsidized and very inexpensive. And then the IUAs that we mentioned, these are the options. These are the most popular options. These options are available as well on the right. There's 1,000, 1,500, and 2,500. But the most popular options are the lowest one and the highest one. This would be for people who are super budget conscious, and these are people who want the lowest IUA. So depending on what's more important to you. And then there's these options in between. But if you take a look at these pricing or this pricing sheet, you'll notice if you shopped insurance in the past, this is significantly less than traditional insurance. In fact, I'll highlight these numbers here. If you remember, we did that comparison on the insurance side earlier on in this webinar, where we did a an analysis of a 55-year-old couple, and the very cheapest, lowest benefits, but also the lowest cost per month was $1,000 a month. And here, the very best option with the lowest out-of-pocket exposure is $618 a month. So it's significantly less. So on that note, there's a couple of points I want to bring up about how this works. How can Redirect and Sedera do this? There's a couple things I'll bring up. First of all, the pre-existing condition one is huge. That costs the insurance companies, I don't know the number, but it's enormous. In fact, an article I read it's been a few months now, it attributed to more than half of the reason that the cost of insurance has gone up is due to only 5 common pre-existing conditions, because insurance companies have to cover that, even though you don't have to pay premiums until open enrollment. I mean, we've got enough people on this call that I'm sure this has happened to many people, and if not, you probably know somebody who's had a condition that they needed taken care of, and they waited until open enrollment to get insurance so that they could get that condition treated, which is exactly what I would do if I were a member. But that's crazy expensive for insurance companies because they have to cover things that they normally assess risk through their actuaries based on how often people get these things. But the laws have turned it around on them so that people can join with a condition already that the insurance companies have to cover. So that's one reason. That's probably the most obvious and largest reason why this is significantly less expensive, because they put restrictions on pre-existing conditions. Let's see, the other one, this is important too. So members, car members in Colorado, we have hundreds of people that are using Sedera already. However, 12 months ago, there weren't that many, not nearly that many. And people would ask, hey, if I'm one of the first members in this and I all of a sudden have an expensive medical condition, is there going to be enough money in the pool to cover that? And the answer is that Sedera has 30,000 members nationwide, and that community pool belongs to all 30,000 members. So I read an update from them today that they've shared over $33 million in medical expenses, and that's within the last few years. Sedera has only been doing what they do since 2015. They're owned by a large publicly traded medical company, but they looked at the medical cost sharing community that has become very popular since insurance got a lot more expensive. And now that that's available to non-religious groups, they put this in place to help manage that. But the pool is large. There's many members contributing every month, and the pool is based on 30,000 members, not several hundred in Colorado. Let's see, there was one other point I'm forgetting. There was something you mentioned yesterday, Stephen, that I'm blanking on right now. If you can get on and explain that, I forgot what it was. We'll come back to that. But those are the two main reasons how this stays financially viable. Okay. All right. Next, I'm going to go through some examples of things that happen. So we're going to go through examples, and they get more complicated as we go along. So we're going to start with some simple ones and some inexpensive ones, and go up to like a cancer diagnosis at the end and how that's dealt with. And we're going to compare health insurance and cost sharing. So let's start with a sinus infection. On the health insurance side, I've got $35 copay. This is a policy that I used to get some details on these numbers. So this policy that I was comparing had a $35 copay for a primary care visit, and the antibiotic costs a few bucks. So you're out $40 to get a sinus infection taken care of. With the medical cost sharing, that's something that could easily be taken care of through the VDPC, and then you would be responsible to go buy your antibiotic. That might cost you $5. Of course, we're not all here to see how we can make something that normally costs $40 cost $5, but it's nice to know that this can be done quickly and less expensively. I would say the biggest benefit to having it done this way is that I don't have to go anywhere. I can do this from my telephone. I can either call, I can do a video conference, or even instant message with doctors through the VDPC and say, hey, here are my symptoms, here's what's going on, and they can prescribe an antibiotic, send that electronically to the 24-hour pharmacy or whatever pharmacy I want near my home, and I can go pick up the antibiotic without ever going to a doctor office. So the convenience here is a big feature, whereas the cost, it is less, but it's, who cares whether it's 40 or 5. All right, the next one, let's talk about a sprained ankle. Let's say I sprained my ankle And I go to urgent care. The urgent care costs $50. The x-ray costs $50. Those are because I have the copay features on my insurance plan, and I'm out of pocket $100. If I decide to go to urgent care rather than calling VDPC, and this is the solution that I've decided is right for me, this could cost me more than going through traditional insurance. I spend $150 going to urgent care. I pay $75 for the x-ray, which are the cash pay rates. I'm out of pocket $225 instead of $100 if I sprain my ankle. Now, in many cases, this can be done through VDPC, where you say, hey, I was playing softball, I was rounding second base, and I hurt my ankle, and the doctor can say, okay, let's find a place in your area that will do an x-ray right away, and we're going to negotiate the cost. And in the Denver metro area, we should be able to get x-rays for 40 or 50 bucks. If you're up in Vail or out in Crested Butte or something, that might cost a little more. But that could be free if I can resolve that through a phone call and have them order the x-ray for me or tell me where to go and get that. And then they can look at the x-ray and determine, hey, it's not a break, it's just a sprain. Put some ice on it and keep it up, and just you'll heal fine. But let's say I needed to go to urgent care. I'm out of pocket a little bit more this one. Now, let's say that x-ray does not come back so rosy, and instead of it being a sprain, it's a break. So that x-ray comes back, it's a break. The urgent care doctor tells me I need to see a specialist. There's going to be some surgery involved because my bones have shifted. Now, all of a sudden, I'm paying my deductible I'm paying the costs until I reach my deductible, and then I've got a 20/80 split with the insurance company, and I'm out of pocket for that broken ankle, $5,500. Now, this is pretty simple. As soon as I hit $500, because that's the IUA I've chosen with Sedera, I'm done. So I was at $405 up to here. And then once I needed surgery, I only needed to pay $95 more till I got to the $500 IUA. And then any costs beyond that, Sedera Community provides funds for, and I'm only out of pocket $500. Okay. Now let's talk about cancer. This one doesn't get resolved so quickly. I'm going to go through a 2-year timeline for this, but in year 1, I've got a few doctor visits, I've got these copays, I've got a copay for an MRI, and then I've got some surgery for the cancer. I'm out of pocket $7,080 in year 1 for the cancer. Now this works very similarly to the broken ankle. Once I'm out of pocket $500, again, whether that's a broken ankle or cancer, my IUA is $500. Once I'm out of pocket $500, the community provides funding for the rest of the medical bills. So I'm only out $500. Now let's go into year 2, and I still need help with this cancer. I need chemotherapy. I've got some doctor visits, probably more than one, but I'm using this example. There's one more doctor visit. They decide that chemotherapy is the best solution, and I go through that. Now that chemotherapy pushes me up to my max out of pocket. So I pay my deductible, and then I pay a 20/80 split until I reach my max out of pocket, which is $15,800 on this policy. And then I've reached my max out of pocket. So the following surgeries and MRIs and doctor visits, I don't have to pay for those because I've got the insurance, but I'm out of pocket, my max out of pocket that year. Now, because the deductible and the max out of pocket reset on January 1st, my max out of pocket for this cancer treatment, my out of pocket for this cancer treatment is $22,880 over a 2-year period. Now, granted, if that saved my life, that's a good deal, right? I think we can all agree with that. However, with the cost sharing, they do not reset the IUA just because December 31st became January 1st. Because I've spent my IUA on that medical need, doesn't matter what the calendar says, I am not responsible for any more or I don't pay out of pocket anymore for the medical treatment that I need for that cancer. I've already paid my IUA, and the Sedera community provides funding for the rest. By the way, I remembered what the last reason was for the negotiations, or for the cost, how this works. And that's their statistics on negotiating. So when they call to negotiate bills down, their success rate on that is nearly 50%. It's in the high 40s, like 47, 48%. So if you get a knee surgery and the doctor tries to bill you $10,000 or $20,000, Sedera's negotiation success rate in getting that down is about 50%. So that says a lot about our medical industry right now. It's convoluted and kind of broken. I think we can all agree it needs some help. And that's one of the reasons. Like, why would a doctor charge me 20 if they'll accept 10? And that's because billing is difficult. a statistic I heard a couple of weeks ago is that there are 800,000 practicing doctors in the United States, and there are twice that many, so 1.6 million bill administrators for medical facilities. So there's twice as many people handling the bureaucracy of billing as there are people practicing medicine, which is insane. So one of the reasons they're able to get it down and negotiate it so far is they pay quickly and they pay cash. So if they call and say, hey, we have a member that needs a knee surgery or got a knee surgery, and you billed $20,000, we'd like to pay 10, and we're going to pay you next week. It's amazing how successful they are in negotiating those down, because they pay quickly, they pay right away without all the headache that medical providers are used to. Okay, let's see. Okay, now I'm going to show you the resources that we have online for that. I'm going to go back to our website here. So if you go to coloradorealtors.com/healthcare, that will take you to this site. And again, this is where we started off in the presentation talking about this. We talked about what happens when you go down this route. Now, if you go down this route, here's some more resources about it. The pricing is on this page. It'll take a minute for this to load. The pricing of the most popular options is on this page, the $500 and $5,000 IUAs. So you could download that here. If you're interested, if you think this makes sense for your family, and you want to look at pricing for yourself, or look at different plan availability or options rather, you can go here, you pick your plan, and then I already put in my personal information as if, again, I was that couple, age 45 or 55, excuse me. But you can go in and reset that and re-put in your birth date and your whether it's you and your spouse, or you and kids, or you and a spouse and kids. But here are the options that it came up with. The great is just the redirect benefits, so just the VDPC. It doesn't have the Sedera benefits involved. It's very inexpensive for a couple. Again, a lot of people pair this with a catastrophic plan that they might be getting elsewhere, just to have access to a doctor 24/7, help them navigate the care that they would be paying for on their own if they were in a high deductible plan. But if you'd like the Sedera benefits, these two on the right are the highest IUA and the lowest IUA. You can simply enroll. It shows the list of benefits here. You can simply enroll, or you can look at the benefit summaries. I think these are important documents. This is what they look like. But they go through the benefits. When you enroll, here's what you get. Some explanations there. Again, you can just download this or go look at it online if you want to. And then lastly, if you would like to choose a different IUA than 500 or 1,000, then you would click on here. That would show you the pricing for all the options. Has all the IUAs available there. And if you would like to enroll in one that is not the 500 or 5,000, then you would need to do that by calling this number here, and they would help you enroll. We don't have that available online, because that was a major rework of the technology, and it would have delayed this being available, but we hope to have that available in the next several months. We just wanted to get something out there, but you certainly can enroll in those other IUAs. You would just do it by calling this number. And then when you click to enroll, it's very simple. You go here, and if you've ever bought anything on Amazon, you know how it works, or anything online, right? You just enter your information, what account you would like to use for billing. You let them know what local association you're a member of. I think most people on this call are a Denver Metro member. If you're an affiliate member, then make sure you let us know that there. We like to know where these people are coming from. It helps us know where to put resources. And that's it. Then you get welcome emails, and you get all the stuff that you need to be a full functioning student member with these benefits. Let's see if there's anything else that is material that I should add in here. I am done with all the information that we've got. I'm going to leave this up here. This is our contact information. I'm going to stop the recording so people listening to it this doesn't ramble on. Let's see.